In the next 10 minutes, we shall be going through a case taking Aarti, a girl with a presentation that we shall discuss clinically. And after this clinical discussion, Dr. Rucha will take us through the workup and diagnosis, and Shilpa is going to help us with the management, which will be with the lifestyle. So in this process, the first case that we have is a 16-year-old girl, Aarti, referred by a gynecologist for evaluation and management of hirsutism. She presented to the gynecologist with amenorrhea of 4 months duration. She has been having irregular cycles since 12 when she attained menarche. Her cycles are between 3 months each, and then spontaneous menstruation lasting 7 to 10 days. She has history of asthma, which is being managed. Her mother and maternal grandmother all have diabetes. Her mother had GDM when she was pregnant with Aarti. Now, just basis of this, if this is the reference coming to us, what can we think of on this clinical basis? Can we look at ovulatory dysfunction? Yes, because the cycles are more than 90 days apart, or as we know by the criteria, less than 21 days or more than 45 days difference. Or as we know, if a girl does not have menarche even after the breast budding has happened for 3 years, that is again. So the high suspicion of ovulatory dysfunction is here on this presentation. Hirsutism is talking about androgen axis. Alone hirsutism in a young girl, and to the degree of hirsutism, which we don't know, would not be adequate to say that, but yes, it gives us a suspicion. Again, family history of diabetes in the mother and grandmother and GDM gives us again a nudging suspicion that are we talking about insulin resistance or something to the effect of prediabetes. Let's see what more we have. Then we have some details that Aarti's BMI is 27. That again takes us towards a step of obesity and insulin resistance. She has mild acne and upper lip and chin hair. We still have to talk about hirsutism, whether an acne adds to our list of androgen axis, but yes, we still have to evaluate it. Acanthosis nigricans almost takes us to the next level of thinking about her. Insulin resistance. Now, the OBGY who sent us, the patient already has done some workup. Fasting glucose levels are 103. Again, we know what we are thinking about of prediabetes. We have to diagnose. Is that diagnosis enough or not? We will see later. Fasting insulin levels are 32. FSH, LH, the numbers may be within range, but as we can see, the ratio is definitely altered. TSH is 4.9. Now, with all this presentation, what has come to our mind and what would we like to do next? So there are a lot of questions that come to our mind. The first question is, can we at this stage say that does she have PCOS? And if not, then what are the next steps? One obvious step in this audience, because we are dealing with diabetes, is that what would you like to do for glucose tolerance? And that in this girl, Aarti, 2-hour 75-gram glucose tolerance test was done. It was 168, and it showed us that she had prediabetes. So from here, I would like to invite Rucha to take over and take us to the steps that in such a clinical scenario with this information, logically, stepwise, what is it that we would like to work up? And to conclusively say that does she have PCOS? And what more workup can be done for hirsutism and for obesity? Rucha.